Greenlight XPS Standardized Technique for Optimal Outcomes. Surgery and Narration by Dr. Kevin Zorn. The following educational video will highlight the technical aspects of initial steps of the surgery, which include the 5 and 7 o'clock incisions with the treatment of the floor. After careful cystoscopic inspection, the laser fiber is brought in, and initially, in this instances where there are kissing lobes, taking down the adenomatous tissue and treating the mucosa prior to engaging in the 5 o'clock incision. Here we can see a very vascular mucosa, which is slowly treated at a low setting of 80 watts with the vaporization technique. A very slow sweeping speed of 2 seconds at least per sweep is recommended for optimal outcomes. Note that the working space between the active laser fiber and the tissue is less than 1 to 2 millimeters. This can be gauged as the cap of the fiber is 1.8 millimeters and serves as a good ruler for judging distance during treatment. Upon each pass, the tissue groove is made wider. As can be seen here, we're following over the same initial area that was treated in the lower right quadrant of the prostate. Tissue vaporization can be judged by the amount of bubbling, which is a good reflection of tissue treatment. Upon areas of active arterial bleeding, the surgeon should be recommended to take care of that bleeder initially with either the coagulation setting with circumferential painting around the pumping vessel or the vaporization method from a further distance so as to ensure hemostasis. Here we can see the median lobe protruding into the bladder. At this point, within the groove from a 6 to 7 o'clock position, we can treat the undersurface of that adenoma. Note that I tend to use treatment from a 5 or 7 o'clock direction as the surgeon is unable to judge depth when shooting directly beneath the laser fiber. As we draw back from the bladder, we can see the drop-off of that bladder neck with the fibers which are still intact. Here I begin a carving technique in which I simply bring the fiber capsule back and forth to create a groove. And then I widen this groove with a sweeping motion, again from a 5 o'clock to a 3 or 4 o'clock position in a slow sweeping method so as to allow for opening of that groove and not burying the fiber in a very secluded, deep, narrow recess. Working in a tight environment with tissue contact risks getting tissue stuck on the fiber, overheating the fiber, and potentially allowing its degradation. This does not lead to good outcomes and slows the surgeon down as the energy is not all transmitted to the tissue. Here, a strobe-like type of firing is seen, and that is our coagulation method. As can be seen, those small bleeders at the bladder neck are now controlled. Again, using sort of that carving technique and following the adenoma plane, similar to some of the enucleation techniques, we can begin to free a good portion of that left lobe, which will then either be vaporized or in some instances removed through an incision technique. With the 180 watt setting, I feel that this is no longer required as the power compensates for the slowness of the previous generation's laser vaporization. Here we go back from the groove, aiming more into the adenoma and keeping an eye on the distance from the trigone and also allowing the bladder and the small microparticulate to be removed. Here at that bladder neck, again, we see very small blood vessels, and using the coagulation, we'll simply want to stop these before they cause trouble in the remaining part of the surgery or in the post-operative period for allowing the patient to be discharged home without the catheter. At this point, the surgeon can also come over to the other side, which in this instance is the 7 o'clock position, and create that same groove down to the same level, and therefore allow the median lobe to have its depth already marcated by the fact that we've already gotten down to the capsule. Again, a slow sweeping method from a 7 to a 9 o'clock technique is performed to debulk some of the right adenoma, or in this instance, the patient's left side of the screen, which represents the right side lobe. Occasionally, one may encounter a small bleeder as we see here, either working in a separate area or simply debulking and coming back to find that vessel would be recommended. Here we slowly come back from the bladder into what appears to be bleeding within or behind that tissue. So what I'm going to do is simply create a working space to really identify that vessel. Sometimes in doing so, the laser energy is dispersed and coagulates that vessel, or in the event of an arterial bleed, debulking the tissue more proximal to the camera allows the surgeon a better vision of what's going on. As such, taking the necessary time and providing a more accurate firing of the laser into the bleeder will allow for more effective hemostasis. So as such, we can see there is still some oozing coming from the lower segment of the screen, and simply working to get rid of some of the adenomatous tissue allows us a much more precise understanding of where the bleeding is coming from to achieve hemostasis. So again, we're coming down from the bladder neck, and that is where you will most likely encounter the transversalis fibers of the capsule than anywhere else. So taking the time to identify them and then working along that plane allows for a complete removal of adenoma and therefore reduces the chance of recurrence in the future for this patient. This sweeping is continued back till approximately 1 centimeter proximal to the verumontanum. I routinely perform a coagulation marking of this area so as to be a visual scale or marker so as not to pass this and therefore potentially lead to sphincteric insufficiency and therefore stress urinary incontinence. It is a very small technical maneuver that I found has helped ensure a safe procedure, particularly when treating the anterior spaces where the verumontanum cannot be seen. Here again, although we are aiming most of our energy into the lobe, the right lobe of the patient, this will allow us a better visualization of that groove down to the capsule. Here we are simply sitting in the bladder, allowing some drainage of the small particulate and allow for better appreciation of any significant bleeds. We now come back to the 7 o'clock groove, which still has a small bleeder and is not fully down to the capsule. So such will take the necessary time to treat that bleeder and ensure that we've gotten to our proper depth before firing into the adenoma and treating and completing our floor. So as such, we see here a small little pumper. It's deep into this recess, so simply coming into this area, sometimes just using the vaporization itself is sufficient to slow things down. Sometimes it may open up another small adenoma vessel, and if that's the case, we will come in more securely and treat it with hemostatic power, which would be around 35 watts. And there we go. We've created good hemostasis. We can start seeing some of the fibers of the bladder neck, and simply dragging the fiber back will allow for that homogeneous groove to be made, and then simply widening it out with some small rotations allows for a more broader groove and therefore a larger working space. It is important to make sure that water flow is continuous around the fiber to keep it cool and therefore provide good energy delivery. Here again, we are simply dragging along and aiming in a 9 o'clock direction and to undermine that adenoma along the surgical capsule. Energy setting here is usually 120 to 100 to 80 watts at full power. Selection of that energy source is surgeon dependent and also related to the prostate volume and consistency. What is interesting about the prostate is that it is not a homogeneous tissue structure. There are areas which will be much more stromal and more fibrous, will take more energy and slower treatment time. And this compares to other areas which is very glandular, very vascular, such as the mucosa or other areas, particularly the lateral lobes, in which the tissue will simply bubble away with very meticulous ease. And this can be seen here as we're firing into the right side, big bubbling, tissue removes quite easily, and this is more of a glandular tissue. Occasionally during the same pass, we'll get into an area which is more fibrous, and simply slowing down on that area, treating it through several other sweeps may be necessary to create a much more homogeneous groove. So it is important for the surgeon to be more aware, inch by inch, of the tissue consistency and make those small adjustments so as to allow for a much more smooth groove as we're seeing here at the 7 o'clock area compared to other areas of our treatment. If not, the surgeon could get much more spotty or hill valley-like types of groove making, and this will lead to a much more fluffy and irregular surfaced treatment area. Here we move ahead and simply begin our treatment along the adenomatous plane at the capsule and to start treating the floor. The power is usually brought up to 180 watts, and we are simply going to side fire so as to allow treatment of the energy into the adenoma and not toward the capsule and the nerve fibers, which may cause more dysuria. Simply dragging along the base with the aiming beam first shown at the bladder neck, we simply withdraw toward the verumontanum. In some instances, some surgeons would like tissue, and this could easily be truncated at its base, and therefore small pieces can be later retrieved for pathological analysis. For instances where cancer is not suspected and where time is not of a more sensitive nature, these pieces can simply be kept on the stalk and vaporized down, and therefore no pathological tissue needed. Occasionally we may have these little pieces that stay at the bladder neck, and these will simply fall off with some time. It is also important to recall that the circumferential area that is seen here within the prostate will slough off approximately 2 to 3 millimeters of tissue. This is the coagulation depth of this laser, and as such, this superficial layer will be passed in the next 2 to 3 weeks period. I routinely advise my patients that there will be some dysuria or irritation during urination, as well as some particulate in their urine for up to 2 to 3 and sometimes 4 weeks.